Hi, Dr. Tony Scuderi here with part two of counseling techniques. And I'd like to get back to um, what we were talking about the last time. This is going to talk a little bit about Johari window, and we're going to close off with that basic counseling. The Johari window, if we take a look at what this is, it's basically if you take a window, take a square, put a cross in it, you're going to have four panes. That's what this is. So the Johari window was made by Joe Lufs and Harry Ingram. Okay, Ingham, not Ingram, Ingham. It was designed the process to clarify the kinds of information that people need to know about themselves. All right. So a window is used as a visual way of describing information available about any person, and you're going to see how that works. And these are the four panes. Got the open area. In the open area, which is the first quadrant, you'll see these quadrants in another slide. This is information that is known by all. You know things about me. I know things about you. The world knows things about me. The world knows things about height, weight, eye color, posture, size, all that stuff. How you talk, how you don't talk. If you listen, you don't listen. You know, it's what you present out there. The next pane is your hidden window. This is information that's known by you, but not by others. This is your hidden side. This is the part of you that you don't want anybody to know about. Right? It could be your manipulative side. It could be your seductive side. It could be your side that knows how to do things to get what you want. Right? All kinds of stuff. Right? The things that people you don't want people to know about you. Very well hidden. You know, as we would say back in South Philly, you keep it close to your chest. Right? That kind of stuff. The third area on the bottom is your blind area. Blind area is for information that's known by others, but not by you. See, this is stuff that's called an unconscious projection. These are things that you have inside you, but at the same time, since they're inside you, other people will see these, and you won't. In fact, you'll contradict it. You're not a very nice person, are you? What do you mean? I am a nice person. But yet your actions that are so common to you may be seen as not being not very nice to other people. You know, little things like, or oh, I'm a really good listener, and as somebody's talking to you, you're kind of going off. Oh, I'm sorry, what was it saying? Right. So that's your blind area, information that's known by others but not by you. And then you have your last area. This is called the unknown area. This is the total unconscious. This is information that's not known by anybody but still there, right? You don't know it, they don't know it. But as life goes on, different things start to emerge, different experiences start. All of these experiences come up from things on the outside that are inside and are projected inward into you. For example, you may have a decent lifestyle, that all of a sudden abuse will happen. Well, when abuse starts to happen, trauma starts to occur. When trauma starts to occur, defense mechanisms kick in to protect the host, you, the body, they bury, they repress, right? Over time, this repression can come out in many different symptoms. It can come out as somatic symptoms, body symptoms where the hurt and feel maybe headaches, migraine headaches, heart problems, stomach problems, gastrointestinal, or they may have a dissociative identity disorder, right? Where it gets so embedded, it fractures them with inside their persona. And as it starts to fracture their ego, they dissociate. So it used to be called multiple personality disorder. Now it's called dissociative identity. Okay? Traumas will do this. It could be racial traumas, it could be violence, it could be beatings, it could be physical abuse, emotional abuse, anything. That's in the unknown area. So as you interact with people, maybe some of these things start to come out. So Joe and Harry took a look at these kinds of windows, and they came out with this. It tends to build a sense of trust and rapport between the counselor and the client once you start to know and understand where the client fits in these windows, where they are. So it's a sense of discovery. I'm going to start to discover the things I know about myself, start to discover from you the things that I don't know about myself. And the things that we don't know about each other, we're going to start to understand that about myself. So it's going to reduce the client's feelings that they're unique because we all share a common thing, and they're not alone. Right. And this brings me to the last example I gave you in the last class about somebody asking me, "Are you in recovery or not?" I don't need to be in recovery to treat a drug and alcohol patient because I'm not treating the drug and alcohol. I'm treating the patient. So I'm not interested really in the drugs that they're taking. I mean, I know, of course, I want to know what they are, so I know how they're going to be affected physiologically, neurologically, and all that other kind of stuff. But what I'm more interested in is how am I going to get them to stop using? So to get them to stop using, one of the things I'm going to be doing is I'm going to be taking a look at them, right? And I'm going to be going on the feeling side because I have feelings. And if I can connect to those feelings, I can have a session. I don't have to know that this person used drugs because they're depressed. All I need to know is depression because they use drugs as a coping mechanism for the depression. I don't use drugs to cope with my depression. So I can draw from my skills because I know what it is to be depressed in my own way. I don't know how the patient is depressed, but I know the word depression. I know the signs and symptoms of it from my diagnostic studies, right? So I understand depression. I also understand how to cope with it. That person understands how to cope with it too, with cocaine or something else. So I can draw from my personal experiences of not using to teach them how not to use and to give them skills without sitting there and saying, "Oh, I don't use, let me tell you what to do." No, I have these feelings. "Oh, so you're depressed." So when it seems to them that I'm telling them this is what you do not to use, what I'm actually doing is I'm telling them this is what you do when you start to feel depressed. So now instead of going to the drug, they're going to go to the coping skills. See how it works? Well, I feel anxious. That's when I use heroin to calm me down. You know, well, I know what it is to be anxious, right? Severely anxious, right? But I don't use heroin. I have other skills. So now I can talk about skills like that to the other person. So hit them on the affective, on the emotional level. That's what this is. So by using the Johari window, it can help reduce the client's feelings that they're unique. Right? It often enables the counseling relationship to move to a deeper level because it leads to inner exploration. It gets the person to do some introversion, internal looking, right? It fosters a feeling that I am walking with this person. I can walk with them. So it's empathy. The client perceives the counselor may need to be able to see things in a different view, their view. And when you sit there and you say, I understand this, and you can say it one pain at a time. And when the patient starts to understand that you understand them on the affective, emotional level, which is deep inside the unconscious level, if you understand that and they know it, they're going to work with you, right? It tends to promote the expression of feelings by the client in the counselor relationship. They're exploring it more, they're drawing it out, creating an atmosphere in which the client feels very free to express the content of their emotions, the content of what's paining them, what's hurting them, what's happened to them, how they've coped with it. By doing that, you're pulling that stuff out, you're probing it, you're pulling it out, and you're showing these patients that this is where we're what the difference, encouraging the patient to go further. And they will go deeper. They will go deeper. And they're going to start to come up with, hey, what if I did this instead of this? Instead of using, what if I did that? And this is where the conversation comes in, like me and my dad. Well, Anthony, what if you did this? Or what if you did that on top of this? Oh, okay. And maybe it'll come together. You give them an assignment to work it for the week. They work it for the week. They come back. You debrief it. You move on, or you stay with it if they have to. Sharing similar experiences. So when we talk about the self-disclosure, right? You've got to relate it directly to the client situation, right? What are we talking about? So the use of the Johari window with self-disclosure could be, on the emotional level without sitting there and saying, well, I'm depressed too. In my depression, this is what I did. Now, some therapists, I know tons of them. I know psychiatrists that will sit there and tell their patients, that are depressed or anxious. Oh, I had a bout of depression, and I, went under my own psychotherapy as well, and I was medicated for a while and got over the depression. Well, depending on the patient, that may or may not be fine. Is that breaking who you are? Is that going to sit there and say, oh, this guy's a nut? No. I'm going to reveal something about myself. Okay. I'm 63 right now. When I was 50, my 50th birthday, shortly thereafter, I had a heart attack. I didn't even know I was having one. I had a heart attack. So I went to the hospital and, I was awake. I didn't stop or anything like that. I just had chest pains and all that and went to the heart attack. Right. So they did the tests and all this and says that we're keeping you here. There's something going on. And they found out that I had a blockage. Well, the cardiologist comes in and sits there and says, well, tomorrow, we're going to go into surgery and we're going to do an angioplasty. Go take a look up if you don't know what it is. Look. And I said, fine. We talked about angioplasty. And since I know the procedure, I asked him, I says, how are you going to do it? This way, that way, or the other way. Right. And we had a real good discussion on it. Now, what didn't I ask the doc? I didn't ask the doc, before you do the angioplasty, can I ask you a question? Sure. Have you ever had a heart attack, doc? And the doctor says, well, no. You ain't going to touch me. Oh, excuse me? No, you ain't going to touch me. If you didn't have a heart attack, you're not going to touch me. Why? Because you don't know what I'm feeling. It's all textbook what you've done, and what other people told you, but no, you have no idea. You've never had one of those. You don't know the pain. Not at all. You can think you do, but you don't. No, you ain't touching me. Are you crazy? Are you crazy? He's a cardiologist. He's expert in the field. There's some things that you have to trust. I trusted the doctor. A great doctor. Great respect for the man. He did a good job. Not a problem. Knock on wood in years. Ever. Right? Same thing here. Careful when you self-disclose. Right? You don't have to be an addict to treat an addict. Part of what this teaches. Go on the affective level. Go on the emotional level. Right? The counselor should disclose only those experiences that have actually happened to you. If you're going to sit there and you're going to say, well, this is what happened to me, don't go into fantasy land. First of all, you shouldn't be doing that in the first place. Telling patients what you've been through. If you're going to do that, if you choose to do that, make it real. Don't make it up. Because believe me, what happens sometimes is you make it up and it really gets grandiose. And as it gets grandiose, it makes the patient think, wow, I've got God in front of me. And then the patient will try what you did and fail. That's another reason why you never answer the question, Doc, what would you do in a situation? Because if you start revealing and you tell them what you did in that situation, it worked for you, but will it work for them? If it doesn't work for them and something happens and goes really wrong, you're liable. And there's no such thing as they can't sue you, because they're in session. No, they will sue you. This is why I don't believe in separation. And if I do, I'll use it as an example of another patient. And I'll sit there, I'm not going to say this happened with me. I'll just sit there and say, well, I had a patient that had similar issues as you are. And one of the things they went through was this, and they eventually got over it. How do you think they got over it? And I could be talking about me. You never know it. So this is where, you start playing with things that I know about myself, and things that you don't know about me, but I know things that we both know about each other and things that none of us know about each other. Four panes of the Johari window. Be careful of using personal pronouns. I, me, my, myself. It can give a clear message to the patient that, you know, this is your experience. And not only that, but you're switching the session. Because as you tell the patient, oh man, this is what I did. And boy, it was just terrible. I don't know. What do you think? You think I should have done something differently? Now you become the patient. And you can slip into that very, very easily. Right. So you have the option of revealing information about yourself on various levels of intimacy. I can't tell you not to. I can only tell you that I believe you stay away from that. Again, it's controversial. If you read the literature is going to sit there depending on who you read. Yalom, for example, when he talks about group therapy, he's big into self-revelation. He's an existentialist, right? You're going to have some other people that sit there and say, no, don't do it. You're going to have others that sit there and say, do it moderately. You judge, okay? But ask yourself the following questions, right? Is there mutual trust, empathy, and genuineness present? Mutual trust between you and the patient. Careful of that. The word is trust. You're going to have your patients that are your favorite patients. And your patients, you're going to find some of them are going to fall in love with you. And you may fall in love with your patient. They may sit there and say, oh, no, not me, doc, not me. Well, you're probably going to be the first one because, okay? Because you're going to drop your guard. I've seen this so many times, okay? And I've had to fire people because of it. It's not pleasant. So trust me when I say it. You're going to have your favorites. It's okay to have your favorites, but understand why they're your favorites and manage your countertransference. Right? Is it mutual trust? Can you trust what the person's saying? Can you trust what you're saying? And on what level? Trust, don't get mixed up with therapeutic alliance. A therapeutic alliance is an alliance. Doesn't mean I'm going to take you out on a date. It doesn't mean we're going to have sex. I may want to, and you may want to. That will never be revealed. And if it is revealed, you're getting yourself set up for a lawsuit. Lose everything. This is why self-revelation is I'd be very careful. If you're new and you're not used to countertransference, you can slip right into it. And people that are borderlines and people that are manipulative, if you don't know yourself well enough, i.e., the Johari window, don't know that zone, you can slip into it, and there's going to be so much trouble. Right? Empathy. Is there empathy? There should be empathy. Empathy doesn't mean self-revelation. Empathy means walking in the shoes. You understand how they feel, and you are genuine. You are right there in the present. Something you disagree with, can you tell the patient, "I can't treat you"? You know, this is out of my scope of practice, or I think we're getting too close, and I'm starting to feel very uncomfortable in this situation. I think it's time that we end sessions, and I give you another referral. I'm sorry, we can't do this anymore. And the patient's going to kick and scream, "Oh, you're the best therapist I've ever had. You're this and that." And if you don't have yourself in control, your head's going to get really big. And you're going to sit there and say, "Well, I'll give it a second." And then as the person starts to talk some more, it's going to be an oh. And then the next thing you know, you're going to find yourself in fear. Read some literature on transference and countertransference, and also read some literature on therapists that have gotten themselves in trouble and have lost. Read their stories. You'll see what I'm talking about. And seriously, if you do reveal anything about yourself to the patient, is it for their benefit or yours? Hmm? That's another thing you need to look at. So, will it benefit you or the client? Take a look at this. Try to understand it. So, here are some of the problems that I enumerated. Self-disclosure in the present, here and now in the session, it can have immediate and sometimes extreme effects on the client. How did you deal with it, doc? Oh, I dealt with it this way. We'll go home and do it. Something bad will happen. You're in trouble. I'm just going to give you the negatives. I'm not going to give you the positives. The use of counselor self-disclosure shifts the focus of the session away from the client to the counselor. And that happens a great deal. I remember when I had to do video presentations when I was working on my doctorate in marriage and family couple, and I was very tired that night when I had them in session, and I tried to act like I wasn't tired. I was just perked up. And then as the session went on, I started to reveal some stuff about myself and didn't even realize it. And the patient sat there and says, "Well, do I get paid for the session?" I'm like, "What are you talking about?" And she says, "Well, I just gave you advice on your problems. You know, um, I felt like I was the counselor." I was so embarrassed, and I won't even go into, how I processed that in supervision because I took at least a session and a half with my supervisor and hugely apologized. It wasn't anything serious, but still, you got to be careful of that self revelation, right? Never done it since. Because you don't want to shift the focus. The premature use of an intimate past experience or a threatening present feeling could make the client anxious and could damage the counseling relationship. Even if it is a close relationship, you tell the patient something about you, and the patient likes you, they'll want to take care of you. So now what that will do is it will shut them down. So now they're going to watch what they say to you because they know that you've been through something and they don't want to hurt your feelings because they like you. It's not about hurting your feelings, it's about the patient. Why you don't reveal things to them. This is why you don't self disclose, right? Because that can also shut the They'll tell you everything, they'll go around it. And then, boy, if you got a job, especially if you hit it, you probe into it, and the person isn't ready to accept it because you haven't dealt with your own stuff. There's a certain amount of risk to the counseling relationship anytime you self-disclose. Okay. So let's move away and let's get back to our basic counseling skills just to finish it up. Um, now we talked about Johari window. Let's talk about confrontation. Confrontation, a counselor's statement or question intended to point out contradictions in the client's behavior and statements, or to induce the client to face an issue the counselor feels the client is avoiding. Confrontation. Confrontation can be done in this tone of voice. Confrontation doesn't necessarily mean yelling at the client and saying, "You're full of shit. Who do you think you are?" Right? That's not confrontation. That's being belligerent and disrespectful. Therapy is not supposed to be fun all the time. It's growthful. People don't like to look at their issues. Nobody wants to be told they have not you, not me. But sometimes as a therapist, we have to confront. Look what I do to you, my students in session, right? I confront you. How come your paper's not written APA? How come you didn't cite? I gave you the PowerPoint. I gave you an example of the paper. I gave you a Zoom presentation, and you still didn't hear me. What's going on with this? What's the resistance? That's confrontation. You do the same thing in session. You can confront your patients. Do it with genuineness. Do it with compassion. Do it with kindness. Right? Don't be the bad parent because your patients are going to look at you as maybe mommy or daddy. That can be their transference. And if you confront them in an angry way, that can either shut them down, that can get them to relapse. If you've got somebody that's got a very weak ego mass, that can dissociate them. I mean, there's things that can come out of it. So always, if you're going to confront, this is how you do it. The client become more congruent, more together, but he or she corresponds with the way they behave. It's called congruency. So what they're saying, and the way that you see them, and the way that they're behaving come together. They're crying. How do you feel? I'm depressed. Congruency. Fidgety. How do you feel? Right now, I'm feeling kind of tense and anxious. That's congruency. Okay. How they respond. Opposite of that is called incongruency. How do you feel? I feel depressed right now. It's terrible. I just can't get over it. I shoot myself. Isn't that funny? That's totally incongruent. You're saying one thing, and like, oh, wait, you're telling me on one side you're suicidal, and the other side you tell me you're fine. Well, which is it, right? It establishes the counselor as a role model in using direct, honest, and open communication. If you're in session with me, what you see is what you get. Okay, I'm not going to sugarcoat anything because my job is to get you out that door. That's my job. My job is to get you out that door. My job is to get you to the point where you're comfortable enough with yourself and the things that you do to heal and to move on. I'm not going to sugarcoat it. That's going to open up communications because you're going to see me as honest, right? Because that leads me to being genuine. If I can't be honest, what the hell kind of a counselor am I going to be? It tends to focus on problems about which the client might take action or change their behavior. Call them on it. Now, you're not going to do this in your first session, folks. You're not going to. You got to get a rapport. You got to get all the basics from the first video that I taught you. Right? Get all those basics down before you come to this part. You know, all of it. You make sure that you have a relationship with the patient. Make sure that you can communicate with the patient. Make sure that when you have sessions with your patient, you can square off. You can be open. You can lean. You can have eye contact. You can relax. Be able to probe. Be able to acknowledge what the patient is saying. To summarize. Be all this stuff, right? Get the patient to know that you're there with them. And then when things happen, you just confront them. How many times have I had a student? Maybe one of you. I don't know. How many times have I had a student that's a really good student, and all of a sudden something happens, and you give me a piece of crap paper at the end if you got a paper, and I sit there and I chew you out in an email, and I sit there and I say, "What are you kidding me? I'm not going to accept this. You're going to have to redo it all over again, and you got one day to do it. You've given me really good papers in the past, and now you're giving me this. Why are you slacking off? What do you think I'm going to do? You think I'm going to give you an A because I like you? Well, I like you, but I'm going to fail the paper. So make your mind up. If you don't want to do the paper, that's fine. You get an F for the paper, and your grade sits where it is. Redo the paper if it's a good paper. If it's a good paper, and you follow what I told you to do, guess what? You got the A. What do you want to do? I'm not doing it out of malice. I'm not doing it out of anger. I'm doing it to teach you a lesson. Be who you are. Right. So it breaks down the defenses of the client. It makes them more aware of who they are. Takes the unconscious and brings it out to the conscious. It enriches the conditions of empathy. How I feel about you. I can walk a mile in your shoes because you know that you can't pull anything over on me. Right. So we're bound together to grow together in therapy. Right. That relationship when the client perceives that confrontation is being done out of concern and not out of malice. I don't confront people because I dislike people. I confront people because they need to be confronted. If I dislike somebody, I don't confront, I attack. Right. And that's different from confrontation. Right? Some people sit there and say, well, attacking is confrontation. Sure it is. But it's negative confrontation. That's not what I'm talking about here. So it encourages the client, encourages the patient to acknowledge their feelings and acknowledge their behavior. It takes the patient and brings all of that stuff on the inside out to the surface that has been denied for years. And once they accept ownership of that, right? Once they own the feelings, once they own the behavior, once they own all that, they're more likely to accept responsibility. Once that happens, man, this is how they start to really see themselves grow. Discrepancies with confrontation. Client sees themselves as how others see them, right? How the client sees oneself and how others see them. Discrepancy there. And this is what needs to be confronted. How the client sees themselves has to be how other people see them, not perceived. That's taught. That's learned. That's probably a developmental issue. Oh, he doesn't like me. Then if you go and ask that person, what do you think about Joe? They're going to sit there and say, man, he's a great guy. So why does Joe perceive Sydney as disliking him? That's got to be looked into. So you confront it. Well, Joe's telling me that he likes you. What makes you think he doesn't? Who's he remind you of? Because probably something in the unconscious that they have to look at. Contradiction between what the counselor sees and the way they behave. The counselor behaves, right? So if I'm seeing something in the session, I'm reacting to that. How am I reacting to what I'm seeing? Am I reacting out of my own stuff? Or am I reacting because this is what you're doing and I'm in control of my stuff? Sometimes there can be a discrepancy there. I can be reading it wrong and never seeing it because I haven't dealt with my thing. This is why you need a good shrink, practice insurance, and good supervision, right? Discrepancy between two statements by the client. Again, we see an incongruency there. Now, sometimes, a client can come into this session if they're manipulative and if they're sociopathic. And you'll get the sociopath, you'll get the psychopath. They'll come in and they'll start a session saying one thing, and then all of a sudden, halfway through the session, they'll go back to what they were saying and say something totally different. You better be able to track and catch that and confront that. Wait a minute, initially you said this was happening, and now you're telling me that this is happening? Wait a minute, what's going on here? Why are you telling me two different stories? Confront that. Don't ever be embarrassed not to do that. Are you going to get pushback? Yeah. Is the patient going to yell at you? Maybe. Don't back down. You don't want to fight with the patient. Don't back down. I'm sorry, this is what you're telling me. This is all I can do. You're angry at me right now. I see that. Tell me why you're angry. Is it because you think I don't believe you? Well, there is a problem here. You're telling me this, and then you're telling me this. They're two different things. What do I believe? I need to know exactly what happened. It's that simple. But yet, a discrepancy between what the client says he or she is feeling and the way most people would react to the similar situation. Sometimes, the clients can get a little bit, this is how I'm feeling, and nobody feels that way. Well, you've got to bring that in and confront that and come up with examples. Even if it's a TV show or a movie. Didn't you see so and so do this or do that? You know, how did they act when they were angry? What happened there? Or can a real life scenario, could you ever tell me a way that somebody had this occurrence happen to them, and after they had this, that they acted differently than that? What did that look like? Then bring that in. Or you could sit there and you could say, well, I knew several people that had this experience, but they felt this way. What do you think that's about? There's a real life experience from you, self revelation, an experience that you had, without sitting there saying, I had this experience. Wait a minute. Some of my friends of mine had the same experience and they acted this way, which is really different from the way you're acting. What's the difference? So what it does, it makes them feel that they're not the only ones. So a contradiction between the client is now saying and believing and how they acted. So the guidelines to confront mutual trust and empathy got to be firmly established. The client's got to like you and trust you. You've got to trust the client and like the client. Come across as being positive and constructive and never as punitive. Never be punitive with the client. Always show caring. Always show caring. It shouldn't be negative, shouldn't be punitive. Confrontation is not necessarily right. Confrontation is pointing out deficiencies and sitting there and saying, this is a growth. You can look at a test two ways. Let me go back to a test, for example. What's the difference between a 100 and a 50? Well, one is a pass, the other is a fail. Wait a minute, let's back up. What's the difference between a 100 and a 50? 100 is a past. 50 tells me what I need to learn. That's all it does. It tells me what I need to learn. That's a guideline. When I was teaching on grounds, I used to tell my students in the classroom, test tomorrow. And they would all go, of course, nobody likes to take a test. I hate tests, but fortunately, they're necessary evil. And I would tell the students, I want you to study really hard for this. Okay? And I don't want you to worry about your grade. Now, the moment I say don't worry about your grade, they start to worry about them. And I'll have a whole class on this. They're saying, no, I don't want you to worry about your grade. I want you to do your best because I'm going to mark what's wrong, but I'm not going to put a grade on that paper. And I'm not going to do it. I'll do it later. And they'll sit there and they'll say, why? And I'll sit there and say, because I need to take a look at what you don't know. I can't teach you what you know because you already know it. But I can teach you what you don't know. You can take your new knowledge and apply it to what was already known. Right? It's positive. It's taking something that's really bad and making them into a positive. So I can confront somebody when I confront maybe one of you for something that I find, you know, incomprehensible, or something that how come you're not doing this, or maybe you're a week late or 2 weeks late in your assignments, and I sit there and say, why are you 2 weeks late in your assignment? I'll send you an email on Friday or Monday, you know, because the class is a 5 week class, ends on Sunday. Friday comes, I'll sit there and say, hey, the week is almost over. How come you're missing these 3 assignments? That's confrontation. And then I'll always put in there, please, if you're having a difficulty, call me, text me, let me know what's going on. So effective confrontation responses are those that address specific, concrete attributes of the client. Always start with something positive. You do very good work. However, this time we need to talk about some things that you need a little bit more work on. Not, you do good work. How come you screwed up now? What's the matter with you? That's not what you want to hear. Right? All right. Mutual trust and empathy must already be firmly established in the relationship. Come across as positive and constructive, right? And effective confrontational responses address specific areas in need of growth, and you move through them. The next area of your basic skills is reframing. Framing sometimes skillful counselor can change the way a client perceives events or situations by what's called reframing. Reframing the picture. If I have a picture and you can see behind me, right? I've got a picture here, right? This is one of my judo certifications, right? So as you can see, it's got a white, it's white, all right, on the inside of the paper, and it's got a black frame around it, right? So what pops out in the picture? All the black writing. Yeah, you notice the red writing that's in there, but for the most part, you recognize the black writing. Now, what would happen if I were to change the color of this frame to red? Well, the black would be there, but the red would pop out, right? That's what happens when you reframe. You're pulling out a different type of, if you will, color from the person's emotions, a different color from what the person is saying from their affect. Right? And the skillful counselor can take what the patient is saying and reframe it. Patient comes to you and sits there and says, I can never do anything right. I'm a total failure. I can't take anything. I'm just a bad person. Well, can we take that and change it around, especially somebody that's that down on themselves? Well, sure you can. You just reframe it. You can say, hold it right there for a second. Could you tell me one time in your life, just one time, I don't care what it was, just tell me one thing that you were proud of that you did? I want you to think about it. Don't tell me nothing. Well, even if we got to sit here for the next half hour in silence, and I'll do that. For the next half hour in silence, one thing, tell me that you did that was right. Eventually, the patient comes up with one thing. And I'll sit there and say, okay, so you're telling me that when you did this, you were very proud of yourself. Yeah, I was. So life can't be that bad because if you were proud of yourself once, you think you could be proud of yourself again? I think so because I'm proud of you right now. I am truly, and I'm not BSing either when I say that. I'm very proud because that's a milestone. You get a patient that does that, it's like, oh, I can relax for 2 seconds, right? Your work is done for a couple of seconds, right? I'm very proud of you for doing that. You were able to sit there and acknowledge something that you did right and the possibility that you could do something right again. So therefore, you just nullified. Can't do anything right. I think you can. Now, what you do as a counselor, you give them a homework assignment that you know they can't fail, and then let them come back and reinforce it, and then give them another one a little bit harder, and you keep doing that a little bit each session. Right? Reframe it. The counselor, metaphorically speaking, puts a frame around the picture, around the patient, around the affect, and makes it look differently. The idea behind reframing isn't to deny the way the client sees the world. I'm not denying this black frame on how you see the certificate, right? Black or the red, but presents them with an expanded view of the world. Um, I get the impression that you're really important to your son and that he wants lots of attention from you. This comes, let's say, from a father that sits there and says, you know, um, or I don't know if my kid likes me or not. I just don't know, right? So I would sit there and I would say, so how do you know that your child doesn't like you? Well, if he talks to me, he just sort of a little bit nuts and then walks away like I don't really matter. So I get the impression that your son talks to you. Yeah, he talks to me. Does he ask you things? What kind of things does he ask you? Well, he wants to talk to me about the ball game and should I throw overhand this way or sidearm this way? And I always told him the best thing is overhand that way because it goes further and everything else. And what does your son do? Does he ever follow through with that? Oh man, we were at the game last week and he just almost struck them all out. It was wonderful. He threw overhand. Yeah. Well, I get the impression that you're really important to your son. He wants lots of attention from you, and sometimes that's the only way he can get, especially as a teenager. It's not cool for a teenager to, ask dad for stuff all the time. You got to ask your friends. So he comes to you every once in a while, and it may be that you feel a little standoffish, but he's listening to you. He threw overhand instead of sidearm, right? Oh wow, I never looked at it that way. Reframing, normalizing. This is going to happen a lot in your sessions. It's a particularly useful and very powerful tool if you use it correctly. It takes confusion, it takes chaos, and puts order into it. A person's anxiety, for example, can be considerably reduced if they can recognize that their emotional state is a normal state and an appropriate one for the situation, instead of them going completely off. Now, how can you sit there and say, well, wait a minute, doc, what do you mean? Reduce it if they recognize their emotional state is normal. So somebody's allowed to be anxious. Yeah. Well, how's that work? Well, here's how it works. I'm going to give you a test tomorrow, and I'm going to put it online. You're going to take that test, and I'm not going to tell you what it's in, but it's going to count towards your final grade. Now, how do you feel right now? Oh, hell, man, I feel anxious. Right. Is it appropriate anxiety or not? Yeah, it's appropriate. I think. You don't think it is. Because I just shot your anxiety because I told you that I'm going to give you a test and it's going to count towards your final grade, right? And I'm not going to tell you what's on the test. So now you're going to feel that anxious. That's a normal anxiety. Um, Snakes. I hate snakes. I see a snake. The first thing is, but it's interesting because the ones that I can identify, I'll still keep my distance, but I won't panic. Ones I can't identify, I have a fight and flight response to it. Is that a normal anxiety? Well, it's a phobia, doc. I didn't ask you that. I asked you, is it a normal anxiety? Well, yeah. Why? Because I don't know how to recognize just snakes, right? So it's normal. A counselor who is in doubt about a person's condition, psychological condition, you need to consult with your supervisor. Again, I go back to you need a supervisor, yeah, shrink and malpractice insurance. You really do. Outside, always, if you're treating somebody, always be in therapy yourself. Because if you're not in therapy by yourself, there's going to be, you're going to have too much countertransference popping up at the wrong time. So if you're in doubt about the way you're treating a patient or about a patient's thing, go to supervision. Talk to your supervisor about it. It's okay to talk to a colleague, but go to somebody much more experienced than you. Okay? Go to somebody that's much more competent. Okay. Normalizing can be used to minimize an emotional state. It can be used to normalize changes in behavior. It can be used to normalize roles. It can be used to normalize relationships due to developmental crises. So, as you talk to your patient, you're going to find that their experiences that they tend to take and blow out of proportion are common, ordinary, everyday experiences that they can work through without overreacting. Drug addiction is not normalized. Drug addiction is a response to an oppressive, anxiety provoking situation. That is what an addiction is, a response to an excessive anxiety provoking situation. It takes normalcy and pulls it into the abnormal. And eventually, the abnormal feels normal until it becomes chaotic and destructive. At which point, you, the therapist, your job is to take that abnormality and bring it into a normalcy, right? By showing your patients that there's another way to cope with reality other than other than using a substance. So when we talk about normalizing, we talk about all these basic counseling skills. Your job is to sit there and to understand that part of what you're doing is you're taking a chaotic world of an individual and you're trying to put normality in it. You're putting order into chaos. All right. Because a lot of times when you're dealing with an addict, they don't know where in the world or what in the world they're dealing with or who they're dealing with. I'm talking about themselves. They don't know who or what they're dealing with. All they know is they've got this affect, this feeling, this emotion that they have absolutely no idea on what it's about. But it causes them a great bit of distress. And in order for them to deal with the distress, they do what they do best, use. You know why? Because drugs work. That's the problem. Drugs work. They are designed for cocaine is designed for a certain thing. Heroin is designed for a certain thing. Methamphetamine is designed for a certain thing. Right? If you don't understand, if the patient doesn't understand what these drugs are designed to do to deal with their abnormality will seem to them to be normal. Have behavior A, behavior B is to use. For an addict, that's a normal behavior. And that's something that we can't tolerate. This is why our job as counselors, very fascinating job, because we have the privilege to be with our patients in a very chaotic state. And through their intervention, through their choices that we teach them and choices that they make on their own, and the behaviors that they demonstrate to you and to me through the homework that we give them that is successful. By doing these, right, we get to see the patients in a different light and they get to see themselves in a different light. Okay? All right. So I want to thank you. You take care. and I will catch you in the next video. Bye.